Go ahead and get started. I am Katie Tierney. I'm the medical director of the Center for Gender Medicine and Wellness here at Middlesex Health. And we're going to do a vaccine town hall to answer questions about the vaccine itself, how it impacts the LGBTQ community, and then take questions from anybody in the audience who has specific questions about the vaccine, why or why not to get it, and how to go about getting those vaccines. So, part of the reason that we do this is because there is some level of mistrust in the LGBT community about vaccines, about medical care. So we really want to address those issues in particular. So before we get started, I'm going to go ahead and introduce our panelists. I think first we'll have Dr. Laurel Slongwhite introduce yourself.
I'm Dr. Laurel Slongwhite. I'm a family physician with Middlesex Health, primary care. I work out of an office in Madison, Connecticut. And one of the reasons I'm here is, what drew me to family medicine is I get to care about an individual's health, but also the health of their family and their community. All of that is relevant. And I think that's never more true than when we're talking about the LGBTQ community. And I want to make sure that in this particular health crisis, that our community does not get left behind and that you have the right information to make decisions that will help your health and help you to stay healthy.
Thank you, Dr. Slongwhite. Diana Lombardi.
Hi, I'm Diana Lombardi. I'm the Executive Director of Connecticut TransAdvocacy Coalition. And one of the reasons I'm here on this panel is because I lost a friend to COVID. And also the community is under vaccinated, and we have to increase awareness in the community.
Dr. Alina Filozoff.
Hi, I'm Alina Filozoff. I'm the chair of infectious disease and epidemiology department at Middlesex Health. And to echo everybody else's thoughts, I will also say that I would like to make sure that no community is at disadvantage. And when it comes to fighting against COVID and making sure that you are as informed as every other community in making an informed decision about getting the vaccination as soon as you make that decision, and hopefully that will happen soon.
And finally, Tony Ferriolo.
Hi, my name is Tony Ferriolo. I'm the director of Healthcare Advocate International's Youth and Family Program. I just thought it was super important to be here. I'm an advocate for the community for over a decade, and I know how this can be scary. The whole COVID thing is scary. A lot of people have misconceptions about the vaccine. I'm here to let everybody know in my community that we're all here. Middlesex Hospital is here to support you. And I just can't wait to hear from all the panelists, and hopefully everybody will learn a little tonight.
Excellent. So again, my name is Katie Tierney. I'm the medical director for the Center for Gender Medicine and Wellness here at Middlesex Health. And there's a couple of things that we're going to go over. I'm going to give a brief overview of why we specifically care about the LGBTQ community, COVID, and the vaccination. As we hear every day in the news, we have had more than 31 million confirmed cases of COVID-19. It's hard to believe that just a year ago, we really thought that maybe we would be through it in a couple of weeks or a month, or that's what we hoped. And here we are really now in the chronic phase of this. And we've had more than 550,000 deaths in our country from COVID. And, it's sort of surreal, I think, for all of us. We've all seen movies and read books about pandemics, and we fear Ebola. And here we are in the middle of a pretty serious pandemic. So one of the reasons that we really particularly care about the LGBTQ community is because we know our community is more at risk than some other communities, partly because of the people in the LGBTQ community are more likely to be working in places like restaurants or in healthcare, being frontline workers. They tend to have lower incomes on average. And there's a significant distrust of medical care in the community because of barriers that have been put there, lack of insurance. And so we really want to make sure that all the information that you would normally get from a medical visit or from the medical community is here for you so that you can make an informed decision. It is really important to note that we are not keeping data in the United States on the LGBTQ community specifically as it relates to vaccination against COVID. And so we know that we're most likely under vaccinating this one particular community. So we want to make sure that we get out good information. This is just a slide showing how disproportionately the LGBTQ plus community is affected by COVID, especially financially. So, there's lots of side effects of something like COVID, and one of them is financial, related to loss of work, loss of opportunities for work, and that means almost always that there's a delay in medical care or an increased risk for something like contracting COVID. And again, we just want to make sure that we get out all the right information that we have, and we have been updating our information literally to the last second before we went on this live webinar because it is changing consistently. But ultimately, I am so excited tonight to be with these four panelists and to get the questions that come in. We have really amazing information from these four people. I'm going to have Diana, you start with your overview of vaccines.
For me, I'm old enough to remember the polio epidemic, and when I had to take the shots for polio, my parents were really scared with children coming down with polio. One of our neighbors came down and she was confined to a wheelchair. And so I know how they felt when the vaccines came out, that all of a sudden we had our shots and the danger was over. And it just made so much difference on the parents in the neighborhood and the kids. So vaccines are really helpful. Every year I get my flu shot vaccine, and I'm going to get my polio vaccine and shingles coming up. So I'm very pro-vaccine.
So some information about vaccines. Vaccines have been around for almost 1,000 years. And so first we had vaccines against cowpox, and then in the early and mid 1900s, we started to develop more and more vaccines for different things, including polio, measles, mumps, and rubella. All of these things are now common vaccines that all of us get as children, most of us get as children. And this ability to use vaccines to reduce the burden of infectious diseases in the United States and across the world is incredibly important. I think we have been maybe lulled into believing that none of these things are an issue because we have all been vaccinated, so we don't see it as often, but we are definitely the beneficiaries of significant research over time and have been able to benefit from that. So I'm going to let Dr. Filozoff present her slides about the COVID-19 vaccine in particular.
Thank you, Katie. So why are we talking about vaccines? That was a good preview. So there are two ways of getting immunity for many of the infectious diseases. One way is to have the illness itself, and the other one is to get the vaccination. All of us on the panel recommend you do not try getting COVID infection because of a couple of the reasons. Katie, would you, not Katie, Catherine, would you share the slide, please? Okay, first of all, COVID-19 clearly killed many people. And you can see this can't even be compared to our usual reasons for mortality in this country. You can see heart disease and cancer are really up top, but COVID topped even these two common killers. Next slide. COVID leads to long-term consequences. You could see that many people, even after 6 months of having a COVID infection, may be left with fatigue and sleep problems and hair loss and joint pain and heart problems, whether it's palpitations or actual heart problems, smell disorders, appetite problems, taste problems, dizziness, sore throat. I mean, this list goes on and on and on. And there are obviously changes in the lungs that are long-term, and they're visible even 6 months after the infection. Next slide. And finally, our concern is for the rising variants. So as you could see very early on, even this year already, we could see increase in the proportion of variants, which if we are not successful in immunizing our United States population quickly, the variants become more prevalent and then the vaccine's effectiveness will decrease. Next slide. And you can see they're now spread all over US, and that's where we're in a quote unquote a race. We need to be there first before variants take hold and cause another wave of serious infections. Next slide. So the vaccines and infections work the same way. At the end of every infection or a successful vaccine, we want to develop memory B cells, which make antibodies that will fight infection, and then memory T cells, similar way. They fight in future infections. And that's what the current vaccines that are available in the United States produce. They produce memory cells that if you encounter COVID yet again, you have a much lower chance of developing, first of all, serious complications from COVID, or if you were to still develop it, or not to develop disease at all. Next slide. All vaccines, including COVID-19 vaccines available currently in US, undergo all the phases. And you can see in the red box, the current 3 vaccines have emergency authorization, which is a little different from a full approval. In order to get a full approval, you need 2 years of long-term data. Well, we do not have 2 years because we have people dying every day. So that's why this is a surrogate for a safety data that has gone through all the phases that normal vaccine and usual vaccines that we've had in the past have went through. Next slide. And the goal of the quick and mass vaccination is to make sure that even if there are some hot spots, so to speak, of COVID activity, they will decrease very quickly and not spread. So you can see in the third box, when you have 75% or anything above 70% vaccination, those the infections, whether it's with variants or with wild type virus when it comes to COVID, will not extend further, will not cause a nationwide infection again. Next slide. There are currently 3 methods of producing COVID-19 vaccine. 2 of the methods are used in the 3 existing vaccines. If you see under number 3 is the 2 mRNA vaccines made by Pfizer and Moderna. Under number 2 is the J&J and AstraZeneca that is used in Europe. And number 1 is the highly anticipated Novavax vaccine. But at the end of the day, they all come to the same point. They get to the spike protein, whether it's already manufactured, like with Novavax vaccine, which again is not approved yet. And at the end, your immune system produces antibody, and then your immune system also produces those T cells that will hide in your lymph system and wait for the virus to come again, and then they will be prepared and they will fight it off. Next slide. When we compare the vaccines, we can't just compare numbers. We can't say that one vaccine is better than the other only because it's 95 or 93 or 65 or 80% effective. There's a lot of things that come with that number. Timing of the trial is important, of the clinical trial. Location of the trial. If you do trials in US, the sensitivity or the effectiveness of the vaccine would be different from the effectiveness when it comes to other countries. And that's mostly related to the variant spread. How aggressive the wave is. If you have multiple infections every day, the effectiveness of the vaccine is going to be different from very slowly kind of boiling infections. Dosing the vaccines make a difference, some mathematical difference. So what I want you to pay attention to is what's the effectiveness of the vaccine against the most severe outcomes of the infection. And that's really the number you need to take a look at. Next slide. When it comes to mRNA vaccine, it's not a new technology, but it's a first approved vaccine. It produces very good immune response, but it does not alter your DNA. It doesn't get even in the DNA whatsoever. It doesn't contain a chip. This RNA that it gets into the cell is very fragile. Within 1 to 2 hours, the mRNA is out of the cell, and the outcome of that vaccination is going to continue to be in the system without any more mRNA. Next slide. The Pfizer and Moderna tried to enroll multiple ethnic groups to make sure that we could see different effects of mRNA vaccines on different groups. And historically, that has not been an easy way. And specifically, they made an effort to enroll more Hispanics and African Americans. And you can see the numbers here. There is still, compared to whites, not as many people of ethnic descent that we would hope so. Next slide. And at the end of the day, they compared groups that received the vaccine and groups that did not receive the vaccine. And that's how they came out with the vaccine efficacy rate of close to 95% for both vaccine in the United States. Next slide. And now we have an advantage of seeing how the vaccine is performing in real life, because sometimes when you do things in very controlled setting, it's not the same as doing it in real life. So there's data, again, by now we have much more data than this, but this is a preliminary data on nearly 600,000 people. And the important conclusions from this data is 1 dose is not enough. So if you're going for mRNA vaccine, you must get 2 doses, because you can see the differences between being protected for infection 46% after 1 dose and 92% after the 2nd dose. So there is a big difference. But here's the important part. Hospitalization difference after first dose, even after first dose, is already 74%, and after the second, 87%. Severe disease, 62% after the first and 92% after the 2nd dose. These are great numbers. If you remember the flu vaccine numbers, we talk about in some years 40%, 50%. We never get to these kinds of numbers. So the fact that we get a vaccine in a very short time and appears to be safe and very effective is really a breakthrough, scientific breakthrough. And of course, certain people with certain medical conditions at certain age may not be responding as robustly to the vaccines as others. Next slide. The common side effects have to do with the site reactions where the injection was given. Some people develop muscle pain and fatigue and chills and headache, joint pain, and sometimes fever. The vast majority of people develop those symptoms between 0 and 2 days, and the vast majority of people resolve those symptoms within 0 to 2 days. There are some increase in swollen lymph nodes that happened as a result of mRNA vaccine, which has not been seen in, has been really internal instead of external visibility, and also Bell's palsy. But Bell's palsy compared to general population right now is not appearing to be too increased from the general rates. There is always a risk of allergic reaction with any vaccine, including with mRNA vaccine. Anaphylaxis is the most severe of those reactions, when you have either difficulty breathing or blood pressure problems, or you lose consciousness. These are really severe reactions. When it comes to mRNA vaccines, that reaction happened in 4.5 cases per million doses. And when you compare to other vaccines we have on the market, for flu shot, for example, 1.4 per million, pneumonia shot, 2.5, zoster shingle shot, 9.6. You see that it's in the right ballpark, and we do have treatments for anaphylaxis. Next slide. The allergic reactions to Moderna and Pfizer vaccine can happen in those patients who are allergic to PEG and polysorbate. And if you don't know what it is, you probably are not allergic to it. And only these 2 groups of patients have to go to the immunologist and allergist and discuss whether they should get mRNA vaccine. Everybody else who had even severe reactions to any other things, including penicillins and IV contrast and any other things, should continue to consider mRNA vaccines. They will just have to be observed for a little bit longer period of time, which is 30 minutes. After the vaccination. Next slide. Johnson & Johnson is the most recent approval, It is a international trial. So you could see they enrolled many more people of ethnic descent, 45% of worldwide Hispanics, and African-American as well. They also try to enroll people with risk factors like obesity and HIV and diabetes, which I'm sure skews the results of their numbers of overall effectiveness. Next slide. And in US, it appears to be 72% effective and 66% it was effective against moderate to severe disease 28 days after vaccination. But again, when we talk about hospitalization and death at day 28, because that seems to be the peak of its effectiveness, it had full protection for hospitalization and death. And it seemed to have very good coverage for even variants, including the South African variant and UK variant as well. The side effects are very similar, including a possibility of allergic reaction. Now, the most recent news has to do with the clotting events. And there have been reports of 6 women in nearly 7 million doses that have developed. Next slide. Here's a little perspective for you. So this is a slide for AstraZeneca, and this is for patients which has the same problem because it's very similar technology with DNA viruses. For people that have a low, even for people with low exposure risk, you can see short of, if you remove the 29 and below year olds, having COVID is a much riskier issue when it comes to clotting rather than taking a vaccine. Next slide. And then specifically, we're talking about Johnson & Johnson. You can see the chance of death from COVID based on your age, which is increasing exponentially when you get to 50s, 60s, and then eventually 75. And then chance of death from clot related to J&J is consistent and it's really tiny. And you can see the comparison in the right column. There is really no comparison. This is compared to the risk of COVID itself is a really tiny risk. Next slide. And we also, the clots can happen as a result of other things. For example, they spontaneously happen. So you can see in US, in general population, you have 5 clotting events out of 1 million people just spontaneously. Okay, women on birth control may have 0.3 to 1% risk of clotting, and women who are not on birth control even higher than the risk of the J&J vaccine clotting. Of course, if you do both birth control and J&J, there may be a additional risk, but when we're looking at these numbers, this is very, very tiny risk. Next slide. So the clotting happened in all women under 50 within 2 weeks after vaccination, and it seems to be an immunological event, has to do with the platelets clumping and causing the clotting. Next slide. AstraZeneca has the same problem, but it's very highly protective and effective. And I forgot to mention about J&J. As you know, it is on pause now in US. We do expect a decision hopefully by the end of this week, but Europe is rolling out J&J vaccine already because they did, their rationale is exactly this. The risk of a problem with J&J vaccine is not comparable to the risk of having COVID infection. Next slide. And I've mentioned that before, the variants may somewhat escape some of the vaccines, but there is still significant activity for both against variants, even from mRNA vaccines or J&J vaccines. Next slide. And finally, if you have other medical problems or you receive other vaccination, you could still get COVID vaccination. You just have to space it a little bit. So if you take immunosuppressants, prednisone, Remicade, any other infusions that depress your immune system, it is even more important for you to receive COVID-19 vaccine. If you are in need of other vaccinations, spread them 14 days apart. And that's only because we don't have enough studies to say that doing them together is going to be as safe or as effective as doing them apart. So that's to be fair, we just decided 14 days is as good as any time. And if somebody's being tested for TB, we delay it 4 weeks, again, not based on any real good signs, but just to make sure that we don't falsely diagnose somebody with TB when they don't have any. Next slide. And that's it for me, and I'm happy to entertain any future questions.
Thank you so much, Dr. Filizoff. So before we start, a couple of questions that I'm going to ask our panelists. I just want to reiterate what Dr. Filizoff said in terms of how we think about vaccines and how they work. You know, I think our culture is pretty concrete in the sense that we expect medical treatments to work when they do. And I think with vaccines, I think the most common misconception that I see is that the only goal is to stop the infection. In reality, it's to stop the infection, but also to stop the severity of the infection. When people compare COVID to the flu, that's a reasonable comparison just because we understand the flu culturally, but COVID has a much higher risk of death and long-term complications, as well as hospitalizations. And that, you know, vaccination really is a group effort, right? We're trying to protect not only ourselves, but our family members and those around us. So those of us who can get it should be getting it so that we can protect us and our community. So I'm going to ask a couple of questions of our panelists. Dr. Slongwhite, you're up first. My first question is, there are a lot of concerns around vaccine safety as it relates to fertility. Does the vaccine cause miscarriages or infertility? And is it safe to get a COVID-19 vaccine if you are pregnant, planning to become pregnant, or breastfeeding?
So great questions, and it's certainly something that I answer on a fairly regular basis. To start with, there is no evidence that any vaccine, including the COVID-19 vaccines, cause infertility. As with everything else about the COVID-19 disease, as well as the vaccines, these are new. We are continuing to gather new information, but the information we're using right now to make that determination that they're safe, they don't cause infertility, is animal studies that were performed by the manufacturers showed no evidence of infertility or problems for the pregnancies of the animals that were studied. The manufacturers did not specifically study fertility or pregnancy in their human vaccine trials, but there were participants who became pregnant during the trials, all of whom had safe pregnancies and healthy deliveries when they came to term. There's the standard recommendation right now is by the CDC, the FDA, as well as the Academy or the American College of Obstetrics and Gynecology, is you do not have to delay vaccination if you are planning to become pregnant. You do not have to, if you've received the vaccination, you do not have to delay trying to become pregnant. And in fact, although we have not yet specifically studied the safety of the vaccines during pregnancy, based on the technology, the way these vaccines work, as Dr. Filizoff just explained, we do not believe that there's going to be a risk during pregnancy based on the mechanism of action. And in addition to the people who became pregnant during the initial study, the manufacturers are currently enrolling pregnant people to specifically study the safety and efficacy during pregnancy. And people who are pregnant who elect to get the vaccine can volunteer to provide their information and data to the government or to the manufacturers for ongoing safety monitoring. So as more information comes in, we may be able to give more concrete answers to this question. But right now, we do not have a reason to believe that there's a risk to fertility or a risk to pregnancy by taking these vaccines. In contrast, getting COVID-19 infection might affect fertility, particularly in people who produce sperm. In addition, although the relative risk for pregnant people of having a severe disease is lower than older individuals, when you are pregnant, the chances of having a more severe disease are higher than when you are not pregnant. There's also seems to be a higher risk of preterm labor, of hospitalization, or needing to be admitted to an ICU if you contract COVID-19 during a pregnancy. And so what we're really considering is not just the absolute safety of the vaccine, but the safety of the vaccine when compared to the risk the danger of the disease. Currently, my recommendation to my patients is, if you are considering becoming pregnant, or if you are pregnant, get the vaccine as soon as you can. With regards to breastfeeding, again, we have no reason to believe there's any risk to babies from breastfeeding after a parent has gotten the vaccine. And in fact, one of the reasons we recommend breastfeeding in people who are able to do so is so that antibodies transfer from the parent to the baby in the breast milk to help protect the baby against certain types of infection. So we would hope that these antibodies would be transferred in that way. And no reason to believe there's any risk.
Excellent. And I believe data actually came out today that showed that there was no increased risk of miscarriage or fetal distress in people who had been vaccinated compared to the general population.
Great, thank you.
Next up, Diana. Why should LGBTQ plus individuals consider getting the vaccine? When individuals ask you about the vaccine, what do you tell them?
Well, for me, what I say, vaccinations protect not only us, but also the whole community. If you're vaccinated, you're less likely to contract COVID-19, and therefore you'll be less likely to pass it on to somebody else. And also, if you get vaccinated, and if you do get the virus, you're less likely to get it severely, and you won't be hospitalized. And so therefore, getting the vaccine also keeps our hospitals from getting overcrowded. And if you have other health conditions, getting vaccinated will help you more.
One of the things I think that happened last year, especially with the hospitals being so overloaded with COVID-19 infections, was that a lot of, potentially life-saving surgeries for especially trans patients were delayed because we weren't able to do those. And that is one of the reasons why we really want people to be vaccinated, so our hospitals can be open for procedures and for people who get sick for other reasons. Tony, what would you say to somebody who prefers to quote unquote wait and see before getting the vaccine? If they're asking, should I or should I not get the vaccine?
Katie, get out of my brain. So anyway, yeah, listen, I was one of those people. Honestly, I'm always transparent. I was like, I'm going to wait to see. And a lot of things started happening around me. Number one, I knew a couple of people who had gotten COVID pretty bad, and they're not the same people anymore. So I really got scared. And then I realized one day that it's not about me. I mean, thinking about that, I never even had a flu shot. This was something that was a big deal for me, but this is the most selfless thing you can do. I live alone. I haven't hugged anybody in a year. Emotional health is really hard for some people who are isolated because they're fearing of getting the COVID-19. Get the vaccine. It can save your life. It can save other people's lives. And there will be people that will tell you, and I had a few people in my life that said, don't get it, and they had all these different reasons. And I just set boundaries with those people. I'm not going to push my agenda on you. Don't push your agenda on me. Don't wait to see. Don't take that risk, and get vaccinated as soon as you can. Yeah.
I just want to add to what Tony just said, that in the hospital, I see patients very frequently. When I ask them, are you vaccinated? They said, oh, I wasn't going to because I was very careful. And now they're in the ICU. Or there is a man right now in his 50s who is barely holding on to life. And I said, did you get your vaccine? He said, no, my appointment is a few weeks away. So the point is, get it as soon as you can, because you don't want to say, I should have.
Excellent point. So Dr. Slungwhite, for those of us who have been vaccinated, do we need to continue wearing our masks? Do we need to socially distance? Do we need to continue to avoid gatherings? Because I think a lot of us are feeling that pull, like Tony said, after a year of not being able to see people, and especially in the LGBTQ community, who tends to be more isolated than other communities. This is a big deal. What do we do?
So another great question. And I would wrap around to what Dr. Filizov was just saying, that we are so close to the end zone, but we're not in it yet. And you don't want to get this close to beating this pandemic and escaping without a severe illness, and then either become infected yourself or infect others. So to more fully answer the question, we are still recommending taking a lot of precautions after you're vaccinated. First, it's important to realize that the vaccines are not effective immediately, that it takes a couple of weeks after each dose before your body has fully built up the antibodies to protect you. So we typically think of at least 2 weeks after each dose before you have that full effect of that particular shot. So 2 weeks after the second dose, before we think of you as fully immunized. We're still recommending that you wear masks when you go out in public and are around other people for a couple of reasons. One, we don't know yet for the people who can still catch COVID after being vaccinated, whether or not they will be able to pass it to other people. And so we're recommending that you continue to wear the mask so that you protect somebody from you if you happen to be one of those folks who still catches COVID after you're vaccinated. The second is, again, referring back to some of these variant strains that have been identified. We know that some of these strains are escape the vaccines at least a little bit, and we don't know what next strain might be out there. And until we really have gotten the pandemic under control, we have to keep taking those measures to protect against both the strains that we know of and the strains that we don't, that might be next up and maybe more infectious. And lastly, not everybody around us is vaccinated yet. And so we are recommending that you continue to take a lot of precautions to continue to protect the community. Now, that said, when we are fully vaccinated, there are a few things that are safe to do, or that the CDC currently considers safe to do. Spending time indoors, unmasked, with other people who are also fully vaccinated should be safe. Spending time with people from one household who are not fully vaccinated should be fairly safe. But a lot of this continues to be keep taking precautions, keep protecting yourselves and your loved ones.
Excellent. So we're going to get to a couple of questions that really should be important to the LGBTQ community. So Tony, I'm going to give you the first question about vaccine sites. I know I've seen online some places across the country that are asking for IDs or asking for sex assigned at birth and their gender identity. And that has been somewhat challenging for some people because you shouldn't need to answer those questions for a vaccine. So what do you tell people if that happens at their site, or what they should anticipate?
Well, you don't have to answer the question. You can kindly just say, I decline to answer that. That can be your, but prepare yourself emotionally. I haven't heard of any place in Connecticut that's asking that question. I will say that. I'll also say that if you know what site you're going to, you can certainly reach out to an advocate of your community and they can call ahead or, make sure that it's a safe place. I mean, we have to protect ourselves. When we walk into a situation in a medical environment, we're really at our most vulnerable. So I want to make sure that everybody is keeping that in mind. And remember, just say, I decline to answer. And that should be sufficient. But again, haven't heard about it in Connecticut.
Agreed. I haven't heard about it either, but I want to make sure that people are prepared if that question comes up and they have the power to say, I decline. And we also want to make sure that everyone understands that picture IDs are not required to get your vaccine. So if a site is asking for that, you can decline to show it, which should alleviate some of the discomfort if your ID does not match your preferred name or your correct gender. And therefore reduce one of the reasons why people may not show up to get their vaccine. I'm going to take a second to answer the question from our one of our attendees about how this might affect our trans community. So I'm going to direct the question to you, Alina, because I think the two biggest issues for the trans community is going to be one, especially with the Johnson & Johnson vaccine, hearing about the clotting issue, because in trans feminine people particularly, it's one of the things we talk about consistently about preventing DVT and pulmonary embolus. And And the second part of that is for mostly trans feminine people who may have had any kind of silicone fillers. We know that the mRNA vaccines have some side effects there.
Thanks, Katie. So I'm going to give you an unofficial answer because obviously we're waiting for the official stamps from CDC and FDA. So as a doctor looking at the side effects of J&J, I would suggest that people who are receiving hormone replacement therapy not go with J&J and go with mRNA vaccine, because as I showed you in the previous slide, the risk from the hormones alone is low. The risk from J&J when it comes to clotting is low, but combining them together may be a little different story. They may add, it may still be a low risk, but why take that risk if you have two other perfectly good mRNA vaccines that can be used? So that's my answer when it comes to the clotting in people on hormones. And in regards to fillers, silicone fillers are totally fine. Now, if you do have facial fillers, because they contain hyaluronic acid, which is a normal part of your skin, there may be swelling. And I saw interesting photographs from Association from Dermatology, where you could see swelling, not even redness, but swelling, which goes away after several days and with steroids. They're not disfiguring, they're not super obvious. Only somebody who's really looking very closely will monitor them. And that has been reported extremely rarely after mRNA vaccine. But you should be safe to do that.
Excellent.
And there are treatment.
Fantastic. So Diana, if you had somebody who was having trouble getting to the vaccine site, what would you tell them?
Well, you know, as the slide said, if you already have a vaccine appointment and you need transportation, CT Rides will schedule a ride for you to come and pick you up. Their number is 866-766-5516. And it's Monday through Friday, 8 to 5. There's also a phone line where you can call to help make an appointment for vaccination. And as the slide says, the phone number is 877-918-2224 to schedule an appointment. They will help you also with transportation. So for those who are looking for transportation or just scheduling your vaccination, you know, you can call these two numbers to help.
Excellent. And then Dr. Slanwhite, if they need to make the appointment for the vaccine, where should they go?
So the primary website is that I'm sure you've heard of is the VAMS website, which should be, it's up here on the screen as well as in the chat. That is a little bit clunky, admittedly. You first enter your information, then wait for an email. Once you've received the email, you go back to the website, register, and then you look for an appointment. And you can use this to look for an appointment anywhere in the state. So it's pretty flexible. In addition to this, there's a number of places where you can use MyChart. If your physician or you're registered with, say, Yale or with Middlesex Health, they're using MyChart. You can schedule yourself an appointment. And a number of the large pharmacies have their own websites where you can go and schedule appointments there. So CVS, Walgreens, Walmart, for example, I believe all have their own independent websites.
One of the important things
May I just add to Dr. Slanwhite? There is a website called covidvaccinefinder.org. And so all the major retail pharmacies and Walmart will be on that website.
Excellent. And also, if you are getting either Moderna or Pfizer, and so we'll be in a 2-injection series, you need to make sure that you go to the same site for both of those. So if you pick a site that's 2 hours from your house, be prepared to go back there 3 or 4 weeks later. And then the last question I have for you, Dr. Slanwhite, about VSafe. We were talking about these reactions. How do people report that they're having a reaction that they think might be related to the COVID-19 vaccine?
VSafe is a great app that you can use to report any side effects. If you register and download it to your smartphone, for example, it's completely voluntary, but in the first few days to weeks after you get each vaccine dose, you'll receive a text message prompting you to voluntarily fill out brief questionnaire about how you're feeling, whether you're having certain symptoms or not. And this is the sort of information that can help the government and manufacturers monitor for side effects that have not yet been identified. And this is completely voluntary, but helps us keep each other safe. So for people who have not yet received the vaccines, the more of us who participate in something like VSafe, the more information we have to confirm, yes, this continues to be safe, or we've identified a concern for specific people. That strongly encourage you to download it to your phones when you're getting the vaccines.
Excellent. So one thing that I want to make sure everybody understands is that the vaccine is free. If you have insurance, your insurance will cover it. If you do not, then the government will pay for it. There should be no financial barrier, especially with the access to rides. And certainly, hopefully, the community can help each other out as well. There should be no reason for people not to be able to get the vaccine if they want to get the vaccine. I don't think we have any other questions in the chat. A couple of other just small things that are often asked in our practices are about whether or not, if you've been exposed to somebody with COVID, how long do you need to wait to get vaccinated? Dr. Filizoff?
I would wait 14 days because you don't want to get vaccinated in the middle of developing COVID infection, because you may have some unusual symptoms, not because it's going to be really worsening of the vaccine or worsening of the infection, but still, I would make sure that you're not sick at that same time.
Excellent. And Dr. Slongwhite, if you've had COVID-19 and recovered, do you still need to get vaccinated?
Great question. Yes. We know that it is possible for people to catch COVID more than once. We also know that particularly for people who had a less severe illness, the antibodies do diminish over time. And so the protection you receive from the infection is not as strong and lasts less long, is a shorter protection than the protection you get from the vaccines.
And Dr. Filizoff, are we going to have to do this every year?
Well, hopefully not, because if with time it loses its strength, with COVID loses its strength and may become another cold. If it's another cold that doesn't bring you to the hospital and just gives you a few days of discomfort, so be it. And so that's the hope, that we can stop that, but it's going to take a little time. I don't think we're going to be there for the next 1 to 2 years. We're still going to be probably either getting vaccinated, or if the original vaccine lasts that long, because we only know as much as the time has left since the first people got vaccinated. So right now we say 6 to 9 months. Maybe in a year we're going to say 1 year and 6 to 9 months. So we're hoping that at least, and they are talking about boosters if the variants take hold. So hopefully if we are fast enough in rolling out the actual vaccine, we don't have to really get the booster. So that's the hope.
Sounds like another reason to get vaccinated as soon as possible. And then again, for Dr. Filizoff, how soon after vaccination will protection start? And you pretty much answered the question that will probably be protected maybe between 6 and 9 months, maybe later.
Yes, maybe later. I had a paper, I saw a research paper that says that those memory cells, maybe even from previous SARS infection, lasted 17 years. If we come close to that, even if it's not 17 years, that'd be great.
That would be amazing. I am always impressed with what the human body can handle and do.
Yeah, and to your point, because a lot of people say, aren't we oversaturating our immune system with all these vaccines? The answer is no, because on a daily basis, our immune system is controlling trillions. I don't even know the word. It's not trillions, it's above trillions of bacteria in our body and exposures to different elements every day. So we can handle it.
All right, and then we have one more question. And it's not vaccine related, but it's COVID treatment related. Can you speak to monoclonal antibody treatment and who would get that and why?
So we do have a great treatment. This is a monoclonal antibody. There are two different monoclonal antibodies. Middlesex happens to have one of them. It's a combination of benlanivimab and acetevimab. Don't try to pronounce that. We're calling it BAMS for short. It's very nice. And if you are a high-risk person who develops COVID, and you are within 10 days of your symptom onset, this is the best time to receive monoclonal antibody. That decreases your chances of getting hospitalized or getting severe disease by 70%. It's really good. So if you are 65 and above, if you have obesity of any in any age, if you have diabetes, if you have chronic kidney disease, if you're immunosuppressed at any age, if you're 55 and have some lung problems, your doctor can refer you to us. You get an appointment within the same day and you get an infusion within the same day as well. We have a very well-oiled machine to get things done. This is a 30-minute infusion with a little observation time. And most people who we infuse, and we infused close to 100 people by now, did not end up in the hospital. There are still some people who have such a severe disease that they do end up, but they still leave the hospital. I think the important part that even if you end up and you get severe and you end up in the hospital with severe disease, there's a much higher chance that you will beat it and you'll be out of the hospital back to your close to normal and then normal life.
You know, one thing that has occurred to me over the last year is that we were incredibly surprised by how lethal and how damaging COVID was. But when we're talking about 70% reduction in severe disease and 95% efficacy, these are not numbers we see in medicine very often. Often when we're offering some kind of treatment or prevention, we're talking about 50% or less. And here we are with these incredible opportunities. So I want to make sure that everyone listening understands that these scientific breakthroughs that we've had in the last year are really extraordinary. Well, I would really like to thank all of our panelists and especially our team behind the scenes that have been helping with the technological part of this, which is definitely not any of the panelists' specialty, except maybe Tony with his Ethernet wire. I really have enjoyed speaking with all of you tonight, and I know that it's so important to make sure that everyone understands, especially in the LGBTQ community, that they are valued and recognized and deserve not to be left behind in this particular time. So I thank you all so much for your time. I know, late at night after work, I really appreciate it. And also for those of our attendees that came tonight, and we'll make sure that this is available post-recording for people to access on their own. So thank you very much. Good night.
Night.